Okay, I wanted to give everybody that obligatory 5 minutes, but thank you for hosting me. I am so thrilled and honored to be here to talk to you a little bit about vaccines and measles specifically. My name is Paul Mitchell. I'm a board certified pediatrician and currently a fellow of pediatric infectious diseases here at Children's. What that means is I'm doing my subspecialty training in infectious disease. And I'm really thrilled to be here to talk with you today. My plan is to do about 30 minutes of some common vaccine questions to give a little bit of information. And then I would love to leave the second half of this hour for your questions and to be able to discuss vaccines with you. So thank you for having me. I'll quickly talk through some of my objectives for tonight. So I think briefly, I just want to go through what measles looked like in the year of 2025 and review some of the numbers. And then I want to take a step back and use the measles virus and the measles vaccine to talk about vaccine topics in depth. And so using measles as an example, I want to talk to you tonight about how vaccines work, how we study their safety. I want to compare vaccination to immunity from infection. I want to talk about how vaccines are able to decrease the risk of disease and complications. I want to talk about how we determine when to give vaccines to children. And then I will close by talking about school-based disease outbreaks, specifically around measles, and how we can prevent them, in addition to a couple of trustworthy vaccine resources. And then I promise I will eventually stop talking and start taking some questions from you all. So briefly, as way of review, the year 2025, we reported the most measles cases in the United States since 1991. There were over 2,000 cases across 44 states. 1 in 5 children less than 5 years of age were hospitalized. That's about a 20% hospitalization rate, and it is higher than all other age groups. And as you may know, there were 3 confirmed deaths from measles in 2025, 2 of them among children. There were 36 measles cases in Colorado, most of them in Mesa County, but a fair amount in the Denver metro area as well. Many of these cases were travel related, meaning that people caught measles elsewhere and traveled to Colorado, but there was some spread in our state as well for the year 2025. So, measles is a vaccine preventable disease. And to be able to talk about how that vaccine works, I need to first talk a little bit about how our immune system works to fight disease because the vaccines are able to co-opt that immune response to be able to fight these preventable illnesses. So let's talk about the immune system. The immune system's job is to fight off things called pathogens. So a pathogen is any disease-causing organism. It can be a virus, bacteria, parasite. In this case, we'll be talking specifically about the measles virus. I want you to think about pathogens like a door. There are millions of different pathogens in the world that can infect the body, just like there are millions of different doors. Doors may look similar, but to interact with a door, you need to have a specific part. And in that specific part of a door is the keyhole. A keyhole for our pathogen, like the measles virus, is a small protein called an antigen. Like a keyhole, an antigen is unique, specifically designed, and to be able to interact with it, you need a specific key. Just like a key is designed specifically for a keyhole, there are antibodies in our body that are designed specifically for antigens, and they fit perfectly together. So what happens when that occurs in the body? So just like a key goes into a door, and your body produces antibodies, which are able to bind to the antigens of the pathogen that is trying to infect you. These two structures are perfectly designed for each other. Each antibody is only paired with one pathogen, just like one key can only open one door. And what happens when a key is plugged into a door? The door opens, and in your body, antibodies bind to the virus or bacteria or other pathogen and are able to kill it and get rid of it. But you need to have the right key. You can't use any key for any door, and you can't use any antibody to fight any pathogen. So where do these antibodies come from? They have to be around in your body when you experience a pathogen for you to be able to fight it off. To get these antibodies, you get them either through vaccination or through a previous infection. So you have to have some exposure to this pathogen prior in your life so that the next time you see it, you're able to fight it off. That prior exposure then produces the antibody that is unique to that pathogen. So the measles antibody looks different than the chickenpox antibody, looks different than the flu antibody. And you need to have exposure to each of those things to be able to fight them off. But what happens when you get a new pathogen? If your body has never seen this pathogen before, this bacteria or this virus or this parasite, you don't have an antibody to it and you're not able to fight it off. This is when we deal with disease. This is when a pathogen is able to get into your body and cause disease and its complications. And so the goal of vaccination is to provide you some exposure to this pathogen in a safe way so that you can produce those antibodies. So how does that work? There are two different ways that vaccines can train your immune system. So if we're thinking about this new pathogen that we haven't seen before, the first vaccine gives you a piece of the pathogen. It gives you the keyhole so that your body can become key makers and make the key that pairs to that keyhole and allow you to get rid of that pathogen. It doesn't give you the whole thing because that would be giving you the infection. It just gives you a small piece of it and allows your body to produce an antibody, which is then able in the future to fight off that infection. That's one type of vaccine. Another type is how the measles vaccine works. Instead of giving you a small piece of a pathogen, it gives you a weakened version of that pathogen. So we take the measles virus and we alter it so that it cannot cause infection. The small exception to that is people without functioning immune systems, folks who have an immunodeficiency or folks on chemotherapy. There are rare cases where they can be infected with this weakened virus, but most people handle it just fine. So we give you that weakened virus, and just like the other type of vaccine, your body becomes a key maker. It looks around at that keyhole just like they do at Home Depot and makes a key, or in this case, an antibody that is perfectly paired to that virus. So to briefly summarize, vaccines take our bodies to school and they teach our immune system how to fight viruses and bacteria that we may encounter in the world. And they do this by safely exposing you to viruses, bacteria, or other pathogens without having to give you the disease. So I think the next logical question that comes from this is, what's the difference between getting a vaccine and getting the infection itself? You can get protection through antibodies through either infection or vaccination. But what I would like to explain is that vaccination is significantly safer than getting the disease itself, and I'll talk about why. So again, we'll use measles as an example. And to be able to understand the rarity of these occurrences, you have to think about it on a large population level. So I'm going to use a hypothetical example of 10,000 children. If we gave 10,000 children measles to be able to give them immunity to measles, what would that look like? If 10,000 children were to get measles, the rates of complications would be as follows. 2,000 children would be hospitalized. That's 1 in 5 kids, 20% hospitalization rate would require hospitalization from their infection. 800 of those 10,000 children would get ear infections that could risk potential hearing loss. 500 of those children would develop pneumonia, which is a lung infection and is the most common cause of hospitalization in children. 10 of those 10,000 children would develop inflammation in their brain, which is a very serious complication and can sometimes lead to permanent disability or death. And 10 of those 10,000 children could actually die from the measles virus. This is the low end of things. The range is somewhere between 10 and 30 of those 10,000 children would die from the measles virus if 10,000 of them got it. How does that compare to if we gave 10,000 children the measles vaccine? So we're accomplishing the same goal of providing children with the immunity that they need to fight off the measles virus. But what I will say here is that the measles vaccine is significantly safer and complications are significantly rarer. I'm not going to tell you that there are no potential side effects from a measles vaccine. The risk is not zero, but like anything we do in medicine, whether it's antibiotics or blood pressure, there is always risk and there is always benefit, and we have to balance those two things when making the right decision. So let's talk about the potential risks of the measles vaccine. If 10,000 children got that vaccine, 1,000 of them would develop a fever. So 1 in 10 children would develop a fever, usually a one-time occurrence in the day or so after vaccination. It does not recur. It does not cause long-term issues. 500 of the 10,000 children would develop a temporary rash that may look similar to the measles virus rash, but is not contagious. It does not cause long-term scarring, and it resolves after a few days. So these are minor side effects that are less severe than being hospitalized or ear infections or pneumonia, and they're also less common. 2 out of 10,000 children who get a measles vaccine may develop what's called a febrile seizure. This is a seizure that develops in the setting of a high temperature, which we know can be caused by the measles vaccine. It is exceedingly rare, and if it does occur, it typically does not cause any long-term issues, typically does not require hospitalization. It is usually a one-time occurrence shortly after vaccination and is very, very rare. The most serious side effects are even rarer still. Less than 1 out of 10,000 children who get a measles vaccine will develop a blood clot, an abnormal blood clot, and less than 1 out of 10,000 children will develop a severe allergic reaction that would preclude them from getting their vaccines later. So there are potential risks to the measles vaccine, but if you line them up against the potential complications, the vaccine is significantly safer, less likely to give you a complication, and what complications it gives you are much less severe. How do we know all this? How do we know what the rate of complications are? How do we know that these vaccines are effective? So I want to talk briefly as an overview of how we study vaccines in the United States and how we study their safety specifically. So I'll go slowly through this chart, but initially you start with research, which is in the lab, creating a new vaccine product. Once we have a product that we think may be effective, we need to test it on human subjects. So the first phase that happens in is a phase 1 clinical study. This is a very small group of healthy volunteers. We do not look at whether the vaccine works. All we're looking at is whether it's safe. Does this cause any severe side effects that we can detect in this phase 1 study? If the vaccine is found to be safe, we move on to phase 2. In the phase 2 study, we include more people, hundreds of volunteers instead of tens and 20s of volunteers. And this is where we're looking at vaccine effectiveness to see if it is providing the type of protection that we want. Once we pass that step, we move on to phase 3. At this point, we are again looking at safety and whether a vaccine works, but we're doing it on thousands of people, people from different diverse backgrounds, people with different medical histories. We're trying to see if this works on a population level. Once we have all of the clinical study data, it is given to the Food and Drug Administration, who reviews everything that the vaccine manufacturer has submitted and decides about whether they're going to approve a vaccine. There are then regulatory bodies in the United States that review the data and decide and make recommendations on who should get that vaccine, what age groups, and at what point. I want to focus in a little bit on this, safety monitoring. After the ACIP, the Advisory Committee on Immunization Practices, makes recommendations about a vaccine, people start getting it. That is when we're having this protection in our society. But the safety monitoring does not stop when people start getting a vaccine. Vaccine monitoring continues for the decades after it is approved and while it is being given to people. Vaccines are actually monitored more systematically than other medicines in the years after they're given to people. I think the reason for this is pretty simple. With things like antibiotics and other medicines, we give to people who are sick. But vaccines we're giving to people who are healthy, and so we hold it to a much higher standard. So we're not just testing its safety before it's approved, we're also monitoring its safety very, very closely after it has gone to market and people are able to get it in the real world. So how do we do this? I won't go into depth with all of the different vaccine monitoring strategies that we have in the United States, but I want to talk about a couple of important ones as examples. The first is the Vaccine Adverse Event Reporting System. It's called VAERS. This is a spontaneous, voluntary reporting of side effects from vaccines that go directly to the CDC. They get about 30,000 reports every year. What's really interesting about this is you don't have to be a healthcare professional to submit. Anybody who thinks that they have a side effect from a vaccine can submit to the VAERS system. The CDC then reviews this data to look for concerning safety signals among specific vaccines. Another example is a program called the Vaccine Safety Data Link, or VSD. This is a collaboration between the CDC and 11 hospitals across the country. Millions of vaccine doses are monitored through the VSD, and they keep an eye on any potential safety vaccine signals. And then finally, I want to mention the V-Safe program, which was started after the COVID vaccine came about in 2020. This is a CDC program that actually checks in directly with patients after they get vaccines to monitor and give surveys for any potential side effects or symptoms they may be having. And we've gotten over 150 million of them since 2020. So these are just a couple of examples of how we monitor vaccine safety in the United States. It does not stop with phase 3 trials. It does not stop with approval by the federal government. It continues for the decades afterwards. As long as people are getting vaccines, we are constantly monitoring its safety. We talked about safety. I want to talk a little bit about the effectiveness of a vaccine. What does it mean for a vaccine to be effective? I think it's important to state first and foremost that there is no 100% effective vaccine. We have some pretty good ones and ones that work very well, but there is no vaccine that was going to be 100% effective 100% of the time. Believe me, I wish there was. What I can tell you, again, using the measles vaccine as an example, is that we are pretty effective at preventing infection. So if you take a single dose of a measles vaccine, which is recommended to be given between 12 and 15 months of age, that's about 93% effective at preventing a measles infection. If you get your second dose, which is recommended between 4 and 6 years of age, that you are then 97% effective at preventing a measles infection. But infection is only part of it. So we're leaving between 3 and 7% of people who are vaccinated who may still get sick. But getting sick is not the only thing. We talked about all these different complications that you can get from measles disease. And vaccines are very, very good at preventing those complications, even if you do, or even if you are unlucky enough to get sick. This is a graph that looks at all of the measles cases in the United States from 2001 to 2022. And the distinction here is the folks in blue are people who did not have a measles vaccine, and the folks in orange are the people who had 2 doses of a measles vaccine. And this is just raw numbers of different side effects that occurred in these patients. What you can see is that people who were unvaccinated for measles were more likely to get diarrhea, more likely to have an ear infection and risk hearing loss, more likely to have a lung infection, much more likely to be hospitalized, and more likely to have severe disease. So even though a vaccine is not 100% at preventing you from getting sick, they are really, really effective at preventing you from having severe illness that requires hospitalizations and might risk you having one of these horrible complications from measles. That's how vaccines work on an individual level. I want to talk briefly about how they work on a population level. This is a graph that looks at measles cases in Colorado for the last 125 years. It is looking at what's called a moving average of how many cases there were every 5 years in Colorado of measles. And then you can see in 1963, when the measles vaccine was first introduced, the number of cases in Colorado completely falls off a cliff. These vaccines are not 100%, but they are very, very effective at preventing disease, and they have drastically reduced the number of children and adults that get sick with measles in Colorado over the last 125 years. Vaccines work, and they work in Colorado. So once we have an effective vaccine, once we know that it works, once we've studied its safety and we're sure that it is not going to cause undue side effects, how do we determine when we're going to give a vaccine to someone? When is the best time to vaccinate a child against something like measles? For me, there are 2 big considerations to have about timing of vaccines. One is protecting a child when they are most at risk. And the second is vaccinating a child when their immune response to the vaccine is going to be the most effective. Let's talk about risk first. Again, I'll continue to use the measles vaccine, but this kind of thinking will be a little bit different for every vaccine that you come across. But for measles specifically, children less than or equal to 5 years of age are our most at-risk population. If you look at, again, the measles cases from 2001 to 2022, children less than or equal to 5 years old are more likely to be hospitalized. They are more likely to have a measles complication. We talked about some of those already. And they are significantly more likely to have severe disease when you compare them to children that are aged 5 to 19. This is the group that we want to target. So when we as pediatricians and infectious disease doctors are trying to think about the best time to vaccinate someone, we are trying to target a time when we know they are at high risk of severe disease. So let's talk about our second consideration. Vaccinating someone when their immune response is going to be the most effective. I think the easiest way to understand this is to talk a little bit about antibodies that come from mom during pregnancy. So mothers, as we all know, pass antibodies to their babies through pregnancy, through the placenta, and also after birth through breast milk. This is a miracle. It is a wonderful thing that mothers are able to provide to their children. They can protect them from a number of diseases that they have either been exposed to themselves or have been vaccinated against. And they can protect their babies early on in life from some of these deadly diseases. The issue is these antibodies wane over time. And if you want to vaccinate somebody against them, you have to wait until those antibodies are gone. And I'll explain why. If you have antibodies from your mom circulating in your bloodstream when you're a baby, it is going to prevent you from adequately responding to a vaccine. Let's see what that looks like. So for most people, when we give them the measles vaccine, again, this is that weakened form of the virus that cannot make you sick. If you have no exposure to measles before, you had no antibodies around in your system, that vaccine is able to stimulate a bunch of antibodies to be produced. And the next time you see measles, you will be able to fight it off. But if you have mom's antibodies that are floating around in your blood, and we give you a measles vaccine, the same way that her antibody would protect you from the measles virus, it also prevents you from being able to respond to that vaccine. It binds like the key into the keyhole onto that measles vaccine antigen, and it gets rid of it. So now your immune system is not able to respond in the way that we want to that vaccine. This is called primary vaccine failure. For a period of time, this is okay because you don't need a vaccine response if you have mom's antibodies protecting you, right? The problem is that those antibodies go away over time and they don't come back. So once they're gone, they're gone. And then babies no longer have any protection from the measles virus. So our goal as pediatricians is trying to time the administration of this vaccine for when we think we have the best chance of missing those maternal antibodies. So let me show you what that means visually. This is a graph of a cohort of children where they took blood levels of antibodies from birth every month until 10 months of age. You can see that early on, for the first couple months of life, a majority of children still have antibodies to measles from their mothers. They are probably pretty well protected at that point. It's not everybody, it's not 100%, but it's a good portion of them. By the time you get to around 5, 6, 7 months, less than 10% of people now have antibodies passed on from their mom as they have started to wane over time. So this is when we start to think about vaccinating a child against measles. Again, we're trying to target that early life when they are most at risk without preventing them from responding by the presence of maternal antibodies. So if you give this vaccine at different times, like if you give it at 9 months, about 87% of children will respond, probably because there's still some antibodies from mom that are still circulating. If you give it at 12 months, 95% of children respond. We do a little bit better. There are less children who have antibodies from their mother, and they're able to respond a little bit better. And then at 15 months, 98% of children respond. This is obviously more ideal. We want as many people to respond to the vaccine as possible. But this is how we're kind of balancing this timing. We want to give you the vaccine as early as we possibly can. The younger you are, the more at risk you are from measles. But we want to give it to you at a time when you're going to be able to respond to it. And so looking at this graph, knowing that between 95 and 98% of children are going to respond after that year of life, that is how we have come about targeting the 12 to 15 month age range for your first measles dose. So let's look at what the recommended schedule is for measles. This is the schedule from the American Academy of Pediatrics, which is the evidence-based schedule that we are using these days. I will talk a little bit more in depth about that in a moment. But again, 12 to 15 months, for the reasons we just looked at, is when it is recommended to get your first dose of the measles vaccine. The recommended timing for the second dose is between 4 and 6 years. This is not because your body needs 3 to 4 years to be able to be ready for a second dose of the measles vaccine. We give this second dose because this is when children are entering school. Measles is a very, very, very infectious virus, and it is easily transmissible in closed spaces where lots of children congregate, which is school. And so we give the second dose of the vaccine. It is recommended to be given at this timeline so we can catch up as many people as we possibly can before they enter kindergarten and protect them from the risk of a school-based outbreak. But you don't have to wait that long. The second dose of the measles vaccine can be given 28 days after the first dose. That is the earliest possible time that you can give it. I want to make brief mention of any children who are getting an early measles vaccine dose for travel. So if you are a child less than a year of age who is not eligible yet for their first dose of the measles vaccine, you can get an early dose if you're traveling to a place that has lots of measles transmission outside of the United States or inside of the United States with an ongoing measles outbreak. The earliest possible time we can give you that vaccine is 6 months of age. As we saw in our last graph, there's probably still a portion of children who have mom's antibodies circulating. And for that reason, even if you get this early dose at 6 months, you are still required to get your regularly timed dose at 12 months because there is a risk that 6-month dose you didn't respond to it. And we don't want to risk you potentially not having protection against measles later in life. So that's a little bit about vaccines and the immune system and how vaccines are studied. I want to finish with a couple of graphics about what measles outbreaks can look like. So we talked about what it looks like on a countrywide scale. I'd like to focus in on schools. Schools are a hotbed for disease transmission. And again, because measles is so infectious, it's the most infectious virus that we deal with. It is very easily transmissible among school students. These graphics that I'm going to show you come from modeling data that we have done at Children's Hospital Colorado, where we have taken the publicly available vaccination rates at different schools in Colorado. These are real school numbers, and we have run them through a measles simulation. So what would a measles outbreak look like at this school at this specific vaccination rate? So I'm going to compare three different schools that have similar numbers of students, but different vaccination rates. So this school has 252 kids. 95% of them have gotten the measles vaccine, and it would imply 2 doses. So this is a K through 12 school. If one student attends school with measles and we allow a 60-day outbreak to be simulated in our computer model, at the end of that 60 days, only one other student has contracted measles and none of them have been hospitalized. This is the concept of herd immunity. So herd immunity is the vaccination level that you need in a population to help prevent outbreaks. 95% is the number that we target for measles because it is the number that allows us to really shut down an outbreak and not let it spread to too many children, patients, or whatever kind of population you're talking about. So this is what herd immunity looks like, only one other secondary infection. But what happens if we decrease our vaccination rate a little bit? So a similar number of students, 238 kids at a different school, 84% of them are vaccinated. Now when we introduce one student with measles, we allow a 60-day outbreak to run. Now 34 students have gotten sick, more than 10% of all the children in the school, and 8 of them have had to be hospitalized. This is applying that 20% hospitalization rate that we see among children. So a small decrease in how vaccinated your school is can lead to a large increase in the number of kids who get sick as part of an outbreak. Okay, so the last school has an even lower vaccination rate, 73%, but a similar number of students. We introduce one student with measles. We let our outbreak simulation run for 60 days. Now 92 students have gotten sick with measles. That's more than a third of the enrollment of the school. And 23 of those children have been hospitalized. About 10% of all the kids in the school have been admitted to the hospital with measles. So the point of these outbreak simulations is that small differences in vaccination rate can lead to large differences in outbreak size. So you decrease your vaccination rate by only 11%, you drastically increase the number of infections. And the farther you go along, the more kids that are going to get sick. And so the point that I want to make here is that every vaccine matters. It may seem like vaccinating one child to try to protect them is not going to make a difference in the broad scheme of things, but every child that brings us closer to that 95% herd immunity threshold can decrease the size of an outbreak that in serious cases can shut down a school, can force children to stay home from school. Every vaccine counts. I want to make quick note of some of these herd immunity numbers across the country. So this is CDC data that is looking at kindergarten vaccination rates for measles on a state-by-state basis. All of the states that are colored in green here have reached that 95% herd immunity threshold. Everything in yellow is states that are just below that herd immunity threshold, between 90 to 94%. Pretty good vaccination rate, but more at risk of an outbreak because they're below 95%. And then our states in red are less than 90%, meaning they are far away from that 95% herd immunity threshold. Our state of Colorado has a kindergarten measles vaccination rate of 88%, which is 7 percentage points away from that herd immunity. I want to compare us to Texas, not just because we're close in proximity, but because Texas is where a lot of these measles cases originated in 2025. Their kindergarten vaccination rate is actually a little bit higher than ours. And so although we did not see nearly the number of measles cases in Colorado in 2025, we still have a ways to go to better protect our children in our schools. I want to end by talking quickly about what I think are trustworthy vaccine resources out there. There is a lot of information out in the world. It is impossible to live in our world these days with computers and phones and TV and not be bombarded with new information every day. And sometimes it can be really hard to sift through that. And so I want to point you towards some resources that I think are really helpful and that I turn to when I want vaccine information. The first is the American Academy of Pediatrics. The American Academy of Pediatrics immunization schedule is the trusted evidence-based schedule that I and other pediatricians are currently following to help best protect children in our country. I put a QR code here as well as a link to the AAP's immunization schedule. It talks about what vaccines to give, when to give them, potential side effects, and how to time all of those things. It is an unbelievable resource. If you're looking for more frequently asked questions type resources, I have a couple places I'd like to point you as well. The American Academy of Family Physicians has a great website that goes into different vaccine topics. Healthychildren.org has innumerable articles about vaccines answering all of your important questions. It's also run by the American Academy of Pediatrics. The American College of Obstetricians and Gynecologists has a great website for folks who are pregnant or wanting to become pregnant and wondering how best to protect themselves and their babies. The Colorado Department of Health, CDPHE, has great information on immunizations as well. Immunize.org is a national website that has great frequently asked questions about vaccines. The Vaccine Integrity Project, which is run at the University of Minnesota, has great resources. Immunize Colorado is a local non-for-profit organization in our state that advocates for vaccination. And then, of course, our Children's Hospital has wonderful articles on vaccination on this website as well. I'll come back to this slide at the end while we're taking questions so that you can take a picture of these websites if you'd like. Two more things I want to mention, and then we'll get to questions. One is how to identify truthful vaccine information. Like I said, there's a lot of stuff out there. Trying to sift through it all and find the truth is really hard. And so there's a couple of things that I think can be really helpful. One is trying to look for consensus across multiple reliable sources, not trusting a thing you see from one place and one place only. I think it's important to look for the expertise of the information source that you're getting. What is their background in? Why are they giving you this information? It's important to look for motivations of your information source. And the thing I cannot emphasize enough is to talk about your questions and concerns with your trusted pediatrician. I am here to be able to answer questions for you. I know I speak for myself and all other pediatricians when I say that we want to talk to you about vaccines. We want you to feel comfortable. We want to be there for you. So talk to them if you have questions or concerns about anything. I'll make quick mention of some recent changes to the US vaccine schedule that came this week on Monday. So there was an announcement on January 5th, Monday of this week, that we were moving several vaccines from routine recommendations, meaning that they were recommended for everybody, to what's called shared decision-making or high-risk groups only. I would point you again in the direction of the American Academy of Pediatrics. Their vaccine schedule has not changed despite what has happened this week. And the reason for that is there is no new scientific information that has come to light about these vaccines. And for that reason, the American Academy of Pediatrics is my trusted evidence-based vaccination schedule. I'll add the QR code here again. This is where I go for trusted information. So I will stop now, and I would love to take questions about, I think I saw a couple in the chat as we were going along about anything that I discussed or other vaccination questions that could be helpful. Back up a little bit here. This one up. So I'm looking through our chat here. The first question that I see is, does the shot cause autism in children? This is a great question and something that obviously gets a lot of attention as we've had rising autism rates in our country over the last 20 years. There is no evidence, no scientific evidence whatsoever that any vaccine in the regularly scheduled vaccinations that we give in this country has been linked to autism. And this is something that has been very well studied over in the United States over the past 30 years. There have been multiple large trials involving thousands of children trying to find an association between vaccines and autism, and there is no credible evidence that that is the case. I can say that unequivocally. I see a question here about mom's antibodies disappearing over time, vaccines not being effective, and asking specifically about hepatitis B and mom's antibodies and how that's different from measles. Why do we need to give some vaccines at birth? That's a great question. So as we talked about, we try to develop a vaccine schedule that targets children when they are most at risk of a disease. So when you think about something like hepatitis B, children that acquire hepatitis B early in life are significantly more likely to develop chronic disease, meaning they can never get rid of hepatitis B. And that eventually leads to both liver cancer and potentially liver failure. Children who acquire hepatitis B early in life are upwards of 90% more likely to develop chronic disease. And so the reason that we give hepatitis B early is we want to protect you from potential exposures. And so I think the question comes up of if a mother tests negative for hepatitis B, and hepatitis B is most commonly transmitted vertically from mom to baby during the birthing process. If that mom is negative, why do we have to give mom that hepatitis B vaccine? There are a couple of important things to consider here. One is that vertical transmission from mom is not the only way you can acquire hepatitis B. Hepatitis B is a very hardy virus that can live on surfaces for upwards of a week. Most viruses require being inside of a host, a human being or another mammal to be able to replicate. But hepatitis B can live for a week just in a bodily fluid on a surface. And so children are at risk when you go to daycare and you're at the oral phase and you're putting all kinds of things in your mouth. You are at risk of acquiring hepatitis B early in life, even if it does not come directly from your mom. The other thing to note is that there are a lot of moms who seek care in this country without the benefit of prenatal care, and we don't always have the benefit of saying that we have testing for hepatitis B from a mother. And so the safest option from a public health point of view is to vaccinate our children at birth to prevent them from going on to develop chronic liver disease and potentially liver cancer. I think I'm going to stop sharing because it might be easier for me to see some of these questions in the chat if I do that. And that way I can look at the grid here.
Dr. Mitchell, I know you talked
Mm-hmm.
about this in your presentation, but one of the questions came up and is a good reminder. What is the right age for the vaccine?
Which vaccine specifically are we talking about?
The
The
measles.
measles vaccine? Yeah, so the
Yes.
measles vaccine, the recommended time to get your first dose is between 12 and 15 months of age. So right around a year of life. That is when we think you have the best chance of protecting you as early as possible, but also giving you the best shot to respond to that vaccine because we think your mother's antibodies have gone away by that point. So the first dose should be given between 12 and 15 months. The second dose is recommended between 4 and 6 years. But if you are concerned about measles or there is an active outbreak or you're wanting protection earlier than that, in a conversation with your trusted pediatrician, you can get that second dose as early as 28 days after your first dose. I see another question in the chat here about whether the school modeling data is publicly available. It is not publicly available right now, but what is publicly available is the vaccination rates from every school in Colorado. So the way that we did that modeling study was taking the vaccination rates from the Colorado Department of Health and Environment. And those vaccination rates are publicly available. So if you go to cdphe.com, maybe we can put a link in the chat for folks. You can go to the school that your child attends and look at the vaccination rates for all of the required childhood vaccines. And so get a sense that way. It doesn't have the modeling data up there at the moment, but it does give you a sense just from looking at the vaccination rates, kind of what the protection is like at your specific school. Why do mom's antibodies wear off and not the vaccine? That's a great question. So mom's antibodies are not produced by your immune system. They're transmitted through the placenta or through breast milk. And so they are there temporarily and they slowly start to dissipate over time because they are not your natural innate immunity. Versus when you are exposed to a virus or a bacteria, your body produces antibodies that are short-term antibodies and long-term antibodies called memory cells. Those long-term memory cells stick around for long periods of time to help you fight off infection years after you've been exposed to a bacteria or a virus. Because your body produced them by being exposed to a vaccine, it allows you to have them stick around for a longer period of time. Because mom's antibodies were not produced by your immune system, you don't get that same memory response. You just get temporary transmission of mom's short-term antibodies. I hope that makes sense, kind of the distinction between those two things. Should older adults consider that revaccination against measles, and under what circumstances might it be recommended? This is a really important question too. Um, there are a number of reasons that you may need to be revaccinated, but for most people, as in people who do not work in healthcare and are not at high risk of being exposed to measles, If you have gotten a two-dose MMR or measles vaccine series, you should not need to be revaccinated because those antibodies typically last for life. The exceptions to that are people who are healthcare workers, and there are some situations in which you may be tested, have your antibodies tested before you start a job to ensure that you are immune to measles. And if your levels are lower than we would like, sometimes healthcare workers are encouraged to get revaccinated, but they are held to a higher standard because they are more likely to interact with measles. I also want to make a point about antibody testing, which you can do for a lot of different vaccines, but it has come up obviously in the last year for measles specifically because of the outbreaks in the United States. Even if you have gotten the measles vaccines, you've gotten two doses, and you have your antibodies tested, even if you do not have detectable antibodies, that does not mean that you're not protected against measles. The tests are a good way to catch most people who have responded to the vaccine, but they are not perfectly sensitive that they can catch everybody. And even if you don't have a detectable antibody, you probably have some amount of immunity that is going to protect you from severe disease. We just don't have a test for every single part of your immune system that might respond to a vaccine. So to summarize the answer to your question, older adults may need to be revaccinated depending on their working conditions, but most people who have gotten two doses of the MMR vaccine do not need to be revaccinated. Read this question here, so give me 1 second. This is talking about, this is from one of our wonderful school nurses talking about trying to increase compliance numbers. In terms of family or parents prioritizing vaccines. I provided free vaccine clinics multiple times over the past 3 years at our school, and I can continue to struggle to have families engage. I continue to discuss with the same families what is the best way to motivate these families, talking about health literacy and focusing on other issues. I think from my point of view, when I talk to families about vaccination, it's really important to know what their thinking about vaccines are on an individual level. There are innumerable reasons for somebody to be vaccine hesitant or to deprioritize vaccines. And it's really important that you talk to them in a compassionate and empathetic way about what those reasons might be. I think my part of my job is to be able to discuss the importance of vaccines. A vaccine decision is obviously individualized to every parent and family, but I think what I can do as a healthcare provider is explain to them, here are the risks of the vaccine. Here are the risks of this vaccine preventable disease if you don't get vaccinated. All I can tell you are the potential side effects from that. There's a lot more I think that goes into that answer in terms of meeting families where they are and trying to find clever ways to target our at-risk families or our disadvantaged families. But I think the most important thing you can do as a healthcare provider and talking to somebody about vaccines is understand their concerns and listen to what they have to say and not jump right into trying to convince about things. So I'm seeing a question here about breastfeeding moms and whether they should wait until weaning from breastfeeding before offering the measles vaccine. This is a great question as well. There is no good evidence to say that by the time you get to a year of age, even if you are still breastfeeding, that mom's antibodies are still around. So the numbers that I showed you, the children in those studies did continue to breastfeed even up to a year of age. Not all of them, but a portion of them did. Um, and so, regardless of whether you are continuing to breastfeed, by the time you get to 12 or 15 months of age, mom's antibodies should be gone, and that is the safest time to provide the vaccine. So even if you're continuing to breastfeed, that protection is going to go away. It does not get re-upped every time you have a new breastfeeding session. They slowly fade over time as your baby develops their own immune system. That's a great question. So we encourage breastfeeding for those who are able for that early protection early on. But I would not delay vaccination even if you're continuing to breastfeed into a year of age. Just making sure I'm not missing any questions here. So I have a question about whether antibodies from the first vaccination decrease the efficacy of the second dose or booster doses. Does it neutralize the vaccine like maternal antibodies do in young infants? The answer to this is no. So this differs from vaccine to vaccine. There are some vaccines, as we know, where you need multiple doses to be able to develop that immunity. And so for something like tetanus and pertussis, which is a multi-dose vaccine series, you do not negate your second and third doses from your first dose because you need to build that immunity slowly over time. When we talk specifically about measles, we give two measles doses, not because the second measles dose is a booster, but because there are some people who don't respond to the first measles dose. And so if you're somebody who responded to your first dose of the measles vaccine, it is impossible to know with 100% certainty whether that's the case. And so we recommend you get your second one, but it's not going to damage your response by having your first vaccine already. So the antibodies that work in this way are a little bit different than the mom's antibodies, which are going to get rid of vaccines for a baby. That's a great question. I have a question in here about how soon a child can return to school. I'm assuming this is asking about for a case of a child with measles. This is going to be very different depending on that child's vaccination status and the potential outbreak status at the school itself. So I may defer that question to any of our school nurses or public health folks who are on the call who may have a more nuanced answer to that. Maybe we can hold on the return to school question, Aaron, and maybe come back to that one at some point. If there's somebody, somebody from a public health point of view, I think could probably speak to that a little bit better than I could, as I'm not in charge of those decisions.
Absolutely, we can address that in our post-event email.
Okay, thank you. Um, I see a question here about aluminum in vaccines. I think this is a great question as well. How do you talk to families about aluminum? So as a little bit of background, aluminum is what is used in vaccines for what is called an adjuvant. So an adjuvant is something that we give along with that keyhole part of the virus or bacteria. And the adjuvant is used to stimulate a stronger immune response so that you have better antibodies, so that you're able to fight off that infection when it comes. Aluminum, like vaccines, is extraordinarily well studied in children and has not been linked at the doses we give in vaccines to any sort of neurodegenerative, neuropsychiatric complications, and it is perfectly safe at the doses it is given in vaccines. As a little bit of context, by the time a baby reaches 6 months of age, they'll have gotten vaccines at birth, at 2 months, at 4 months, and 6 months. By the time you're a 6 month old, if you have gotten all of the vaccines that are in the AAP schedule, you've gotten about 4 milligrams of aluminum by that point. If you're a breastfed baby, you've gotten more than double that just by the nature of aluminum that is in our bodies naturally. So the amount that we give in vaccines is quite small. It stimulates a better immune response to protect us from these deadly diseases, and it is perfectly safe and very well studied. So that's a great question. And a lot of the resources that I mentioned earlier, healthychildren.org, I know specifically has an article all about aluminum, kind of reiterating some of the points that I just made, but it is a great resource for families who like to do their own reading and be informed about these things. Thank you for that question. Maybe while we're hanging out just for the last few minutes here, I will pull this slide back up with some of those resources that I mentioned. I think is great. A lot of these are great for providers, but they're also great for families too, who have questions and understandable concerns about the science behind vaccines, the safety around vaccines. And so this is obviously a very busy slide, but I think take a picture of it, hold on to it. These are all bookmarked websites on my computer, so I can get to it very easily. Just a couple more minutes here. Again, happy to take any final questions. If there are things that we didn't get to today, I'm sure there are some ways to get in contact with us, and we'll be putting out some information after this meeting. We can include some things. It's kind of a summary of what was discussed today, but as well as some of the questions that we didn't get to, including the one about return to school in the case of a measles outbreak, which is kind of highly individualized and will differ depending on the situation. But I'm happy to hang out for a couple more minutes in case things come up, but I might take a drink of water while we wait. Not seeing anything else come through on my end, Aaron. So I'm happy to stick around, but if folks have asked what they wanted to talk about, oh, maybe there's one more that just opened up here. Yeah, so this is how do we share some of this information more widely. I think trying to get this information out to anybody who will listen, and spreading the resources that we talked about, and kind of, again, using that very very calm, empathetic approach to talking to people about vaccines, trying to listen to what their concerns are, and being there for them. It's the most important thing you can do for someone in this conversation is listen. And so I'm happy to share a lot of this with you all, and the resources from the places that I got it, and spread it wide. We are hoping to protect as many children in Colorado as we possibly can as we continue into a new year of 2026. I think that's our hour. So thank you all for coming. Thank you for your wonderful questions. And for listening to me be the only one talking for an hour, which can be a lot. But I appreciate your time, especially on a weeknight in the evening, and for all the work that all of you do. It's been great chatting with you all.